Good afternoon. I'm Deborah Leff. I'm director of the Kennedy Library, and on behalf of the library, the John F. Kennedy Library Foundation, and our sponsors, WBUR, Boston.com, the Boston Globe, Boston Capital, the Lowell Institute, and the Boston Foundation, I'm pleased to welcome you here. This is a fairly spectacular setting. A year ago today, I was in a very different setting. I was in an AIDS clinic in Zambia. And people lay dying and suffering, but there were mostly no healthcare workers. And the problem wasn't that there weren't funds to pay them, although funds were scarce. The problem was that the healthcare workers had died of AIDS. It's a generation that is being wiped out, and there are not people to build Zambia's future. In one village, I went through the registry of deaths, a big book, and if you went back 4 years, there was one page and it had 3 names on it of people who had died 4 years ago. You went to 3 years and there were 10 names. 2 years it filled a page, and by last year it was page after page after page of young people who had died of AIDS, of the nation's future going away. It's heartening to see, 150, 200 people out to see an economist. I gather that you're not too scared of numbers, but numbers can be scary. 40 million people in this world have AIDS. 25 million people have died of AIDS. 22 million of them live in Africa. Africa now has 15 million children who are AIDS orphans. We can expect that number to triple in the next 8 years. Just 2 weeks before he was assassinated, President Kennedy addressed the annual Family of Man Award at the New York Protestant Council. His words from years ago ring true in today's troubled times. He said, "If the family of man cannot achieve greater unity and harmony, the very planet which serves as its home may find its future in peril." But there are other troubles besetting the human family, President Kennedy continued. Many of its members live in poverty and misery and despair. The rich must help the poor, he said. The industrialized nations must help the developing nations. President Kennedy's 1963 words are echoed in the words of this afternoon's speaker. Professor Jeffery Sachs is director of the Center for International Development at Harvard University. In January, Professor Sachs was appointed by UN Secretary General Kofi Annan as his special advisor on poverty, health, and education issues. He's just returned from the conference in Mexico. The New York Times Magazine has called Professor Sachs perhaps the most important economist in the world. And Professor Sachs has chosen to use that prominence to advocate forcefully that rich nations should contribute billions of dollars to fight AIDS. Without that, he says, developing countries' economic health cannot improve. And moderating this afternoon's discussion is Professor Ellen Ruppel-Shell, co-director of the Knight Center for Science and Medical Journalism at Boston University. Professor Shell is a science correspondent for Atlantic Monthly, and she's written about international health issues, including a terrific cover story on malaria. She's also written for the New York Times Magazine, but I don't believe authored that quote about the greatest economist, and for Discover and the Smithsonian. So I welcome you to today's discussion.
Well, thank you very much, Deborah. It's wonderful to be here, and it's always inspiring to hear President Kennedy's words on these issues, because we're reminded of the incredible spirit that he brought to the office and that he helped to inspire throughout this country. And it is the spirit that I think is going to be needed in this world if we're going to be able to address the scale of the problem that we're here to talk about tonight. You were very eloquent in the introduction. You've seen the horrors I saw the same about a month ago when I was traveling in Malawi, Uganda, and Ghana in preparation in part for the important UN meeting that just took place last week. I've been involved in this issue for many years, but I too had not seen before what I saw this trip, because in a pandemic, the rate of change, the extent of reach of the death and suffering is proceeding so rapidly that even every few months one is caught short by how astounding the encroaching tragedy is. This trip, I went with Bono, our lead international negotiator, on all matters of international development and disease. And Bono and I, and my medical advisor, my wife, Dr. Sonia Ehrlich, a fantastic pediatrician and a specialist in these matters, also went out to visit the villages. And it was literally true what had only been figuratively true in past years. This visit, there were no working age people in the village the day we went. There were a couple of dozen grandmothers, and there were dozens and dozens of their orphaned grandchildren. And the mothers and fathers were all dead. One grandmother after another told us how she had lost 4 children or 5 children to this pandemic and was left with 12 or 15 children. In a year, incidentally, in which drought, like our drought or the drought in Guatemala or other weather anomalies, make us think about that broader disaster we may be fomenting in the world's climate. But the drought in Malawi had left the crops to fail, so one grandmother unpeeled a tiny bag of rotten millet, bug-infested millet, which is what she was going to have for her 8 or 9 charges that evening. This same grandmother, incidentally, had walked 4 times 10 kilometers each to carry one of the children to a clinic for anti-malaria treatment, since without the treatment, children can die of that scourge as well and are dying in huge numbers. We went the next day to a site that I will never forget, as shocking as that one. We went to St. Elizabeth Hospital in Blantyre, Malawi. And if one wants to think about the gap between those who have and those who have not, it could not have been more shockingly graphic than what we saw there. With a country where about 16% of the adult population is HIV infected, almost nobody has the means to get the antiretroviral drugs that could extend their lives, keep the parents alive, keep the farmers in the fields or the doctors in the clinics. And in this hospital, which is the major hospital in the country, there was an outpatient service for those very few individuals that could afford the $1 a day for the antiretroviral medicines. And these are miracle drugs. They work. If you take them, if you adhere to the treatment, even with HIV infection, you can get up from the deathbed and proceed with your life. And in this country, this is the major outpatient service, and there are 400 individuals that can afford to pay out of pocket. And the doctors told us that they were getting a terrific response with these drugs. But right across the hall was the medical ward for those people that cannot afford the $1 a day. And it was a sight that I have never seen in my life. And this is my business. The ward was built for 160 people. That day, when we got there, there were 450 people. 3 to a bed. Literally 2 in the bed, head to foot, and 1 person underneath the bed, either on the ground or on a piece of plastic or cardboard. Not just 3 to a bed, but 3 to a bed dying without any medical care. In this case, the doctors were there. There just weren't the medicines. And AIDS is a relentlessly fatal disease, of course. Without the antiretroviral medicines, the course is sure death, whether in 5 years or 7 years or 10 years. And I have never looked into a room of 460 dying people, not dying because there was nothing to do, but dying because they lacked $1 a day to stay alive. And the whole room was filled with moans and family members attending to skeletal people and no hope, people that are never going to walk out. And this is what's happening all over Africa. In southern and eastern Africa, about 15 to 20% of the population in most of the countries is HIV infected. In some countries, reaches a quarter of the population, as in South Africa now. In Botswana, an otherwise highly regarded democracy known in the world of development for its good governance, 40% of the adult population is dying of AIDS now. Now, it is, I think, a little bit strange for an economist to be telling you these things rather than a doctor or a public health specialist. And frankly, 5 years ago, I wouldn't have understood or known the enormity of this. I work in poor countries for a living. I try to help them with their trade and their exchange rates and their budgets. And public health was not my thing. And I thought life and death issues were much too important to leave to an economist, that's for sure. And I believe that AIDS, which already we knew from the early 1990s, was an epidemic of potentially unrivaled historical significance in the magnitude of what was engulfing poor people in all parts of the world, must be so important that people were taking care of it. And I heard speech after speech, and the hand-wringing and the concerns and the expressions of urgency. So I assumed, naturally, maybe not naturally, but I did assume that this was an epidemic that was attended to by the leading thinkers and doers in public health, and the finance ministers, those who have the purse strings. When I started myself to work in Africa, after having been involved heavily in Latin America and Asia and Eastern Europe, and I turned my own personal attention to African economic issues, not really understanding, I would say, either the enormity of what was happening or the economics of what was happening. I quickly discovered that my counterparts in Zambia were dying at an unbelievable rate. 8 of the 30 professionals died in 3 years in a project with the central bank and the finance ministry. He said, where are the medicines? What's happening? And I started to look. And what I discovered was that the impoverished countries, which I knew, were too poor on their own to do anything. But what I didn't understand was that the rich countries, with all the wealth and in the middle of the biggest boom of wealth in the history of the world also, were doing almost nothing but lip service. Can you imagine, with already more than 20 million people infected in Africa, that the entire rich world the entire rich world was sending perhaps $60 or $70 million a year to all of Africa in the second half of the 1990s, I couldn't believe what I was discovering. And I found the same for malaria, incidentally, for tuberculosis. I came into this only because I was horrified and shocked as a macroeconomist who understands something about the difference of millions and billions, because we deal in trillions anyway these days, that we were doing a pittance. Despite all the words, all the articles, all the cover stories, and everything else. And to this day, ladies and gentlemen, although it's about to change, to this day, if you can imagine, the United States government has not found a way to keep one human being in a poor country alive by providing the financing for AIDS medicines. Not one single human being in a pandemic that's already reached 65 million people. When I say hasn't found a way, I don't mean to suggest it's so complicated. I just mean to suggest that they have somehow not found it to be in the U.S. national interest to this point. So that's why I'm here, because I learned over time that while I was trained to turn exchange rate dials and budgets and tariff policy, and those things count, they really do count. Boy, they're very limited in their power when a continent is being overwhelmed by 3 simultaneous pandemics of AIDS, malaria, and TB, when it's already being dragged down by an unpayable debt, and when the rich world with the greatest riches beyond any imagining, even a generation or two ago, could not get organized to do something about it, but the platitudes and the words. But before I turn it over to you, because I think I was supposed to say about 30 seconds at the start, let me conclude just the greeting and the opening remarks by noting that perhaps something's finally about to change. Maybe September 11 was more than a tragedy for the United States and more than a call to arms, but maybe it also was a wake-up call for us about our interconnectedness in the world. Maybe it was that, combined with the scale of the pandemic, combined with the eloquence of our Secretary General, who is a man that can work wonders in this world, combined with powerful voices around the world saying that something had to happen. Perhaps it's all of those things that are leading to what I think may be, for the first time in a generation, a wake-up of this country to the truth of what's happening in the rest of the world. 3 weeks ago, I'm not sure I would have expected the speech that President Bush gave 2 weeks ago, where he said that we have to increase our foreign assistance to the poorest countries of the world, and where he made a proposal now to increase U.S. assistance by 50% over the next 3 years. This isn't enough, as I'll say in our discussion, but this is a turn of direction that could prove to be of profound significance. And in Monterrey last week, where there were 50 international leaders gathered and probably 150 countries represented, if not more, not only President Bush, but the European leaders and many others did reaffirm their commitment to international goals that had been set at the start of the millennium, at the Millennium Summit of the United Nations, to reduce poverty, cut hunger, cut infant and maternal mortality, increase access of poor people to clean water and sanitation, improve environmental conditions, and curb the great pandemic diseases. And I hope that Monterey will turn out to be not just another gabfest, but actually a real sign that our country, which more than any other in the world has the power to do something, may have chosen the path that I believe an overwhelming majority of Americans would like to choose, which is to do the right thing and express our humanitarian and national security interests by helping this great struggle. So I think we may be meeting at a time where there's actually some good news for a change.
Well, that is all good, as my kids would say. I think Americans very much want to do good. I'm not sure Americans want to pay for it. And I think when the rubber hits the road, that's the real question. Both you and Deborah Leff were talking about your experiences in Africa. Sorry. All right. Oh, God. I feel like I'm eating it. However, I've been also to various places in the developing world where you still can't. It's not on. Well, it's on? It's louder?
Yeah, that's it. Good. There you go.
Okay. I've also been in places in the developing world where I've seen vitamin D supplementation, for example, which is quite a bit cheaper than AIDS medications, not being available, even in countries where there was not an obvious ubiquitous poverty situation. And as we all know, without vitamin D supplementation, children are more susceptible to upper respiratory infections and will die at a very early age. And it's quite cheap. $1 a day in sub-Saharan Africa might as well be $1 million a day. It is $350 a year, as you know, is what the better than the yearly income of many sub-Saharan Africans. So the question becomes, how much can we supplement this? Is there the will on the part of Americans who are quite suspect, as we know historically, about foreign aid to the developing world? How much political will is there really to see through some of these goals that are quite wonderful? I mean, I don't think there'd be anybody in this room that would say we don't want to help these people. But in all truth, we sometimes have difficulty helping our own here in the United States. This is a huge problem. And the more I hear you and Debbie relating the scope of this problem, I think we're all feeling an enormous weight and exhaustion. And I'm wondering, how are we going to muster the public will around this?
Well, we can't be exhausted yet. We haven't gotten started. We've got a lot of work to do. And I think the heartening thing is it's not as if there's a passive population that is waiting for help. Throughout Africa, throughout poor countries, there are communities that are already organized to try to do the best they can with the means that they have. When Bono and I and my wife went to Uganda, we saw a singing troupe of HIV-infected individuals that go from village to village through song to explain the disease, give heart to those who are sick, and also try to help spread the news of how to avoid infection. The spirit involved in that is unbelievable. These are people that are dying, essentially, and they're giving their last years to this cause. And you see that kind of commitment, of course, from human being to human being everywhere. in these countries. But they also ask the question: Are we not worth anything to be helped? Why are we so abandoned? Why have we been forsaken? And they want to know the question to that. The answer, to that question. If they're given the tools, if they're given some drugs, if they're given some help for bed nets to fight malaria, these communities can provide tremendous self-help. And we see this in all of the cases where we've actually mustered, for one reason or another, some measure of support. No, it's not a completely bleak picture that we've done nothing. There have been, for particular historical cases, great initiatives taken in particular areas. The Rotary International decided that eliminating polio was going to be their mission. And if you look at what's been accomplished with that drive, it's phenomenal that polio is on the verge of a final elimination, like smallpox. Merck, about 20 years ago, it was accidentally discovered had a drug that could cure African river blindness. It's an interesting story in and of itself because the drug was developed for dogs and cows. Almost no drugs for poor people were developed for the poor people themselves. Either they were developed for rich people, or sometimes this incredible accident of a veterinary drug being able to treat poor people's conditions. In any event, Merck decided it would donate these drugs, wonderful contribution, and various private and public groups got organized. And then the Africans all over the continent got organized, and there has been a revolution in the positive sense of ridding vast tracts of Africa of this incredible scourge. So when you ask the question, is it so formidable that there's nothing that can be done? I think that there's all the evidence that people can muster heroic efforts to save themselves and their communities if they're given the tools to do it. The question for us is whether we are going to be in this line of activity of helping to provide the tools. Well, and that's the challenge, I think, that is before us right now.
I think what you said, President Bush's hopeful allocation, even if it goes through, as you said earlier, is only the beginning of what is required. What is required is an enormous amount of money. The big issue for a lot of us, I think, in the United States, I'm playing the devil's advocate here. I mean, I hope you understand, folks in the audience. I'm all for what Professor Sachs is saying. But the truth of the matter is, I think Americans are quite skeptical of foreign aid, and part of the reason we are concerned about it is because we're concerned about corruption in the developing world. Having been in the developing world myself and seen how this operates, and you yourself, and I'm sure many people in this room would agree, that there is definitely a problem with that. There's a problem with credibility. How can we assure that if we make the sacrifices in this country to provide people with these funds, to do the kinds of things you're talking about, that even a small percentage of this will actually get implemented? Now, let me add my own experience, having been in Senegal, for example, which is a country with traditionally wonderful governance by African standards. I visited several clinics. One clinic I saw run single-handedly by a physician who was extremely dedicated, charismatic, the kind of character we all like to talk about and tell our anecdotes about. And he was doing a wonderful job providing service to not only Senegal, but people who would walk all the way from Mali to come to this clinic, which is really quite something. Across town was a hospital. When I went to the hospital, there were no physicians in the hospital. There were only children and their mothers. The mothers brought the children food. The children all had malaria. The physicians had decided as a group, at least the day that I visited, to not be there. As a journalist coming into Senegal, into Africa, this was quite shocking to me. This was not a matter of money. These people were on government salary. And so I think the people of the United States are quite concerned about where our money is going. And I hate to bring it up, but I think the devil is in the details, and as much as we as a people like to do the right thing, history has shown that we often do not, and there are reasons for this. And so I think unless we tackle these forcefully and truthfully and honestly, we're not really going to make progress beyond, frankly, platitudes.
Well, let's move beyond platitudes in a couple of dimensions. First, how much it would cost, and second, what you observed in Senegal. Let me say a word about what the costs are. I think it's a way for us to begin to understand how fantastically rich we are, even if we don't feel that necessarily day to day, even if we feel the strain of our own pocketbooks sometimes, especially in a recession year. Let me just give you a sense of what these numbers are about. I was asked by the Director General of the World Health Organization a couple of years ago to try to put a price tag on how much it would actually cost to address these issues. And so we did something rather straightforward. This was a large team around the world, centered actually at a wonderful school, the London School of Hygiene and Tropical Medicine. We made a list of the core health interventions that are needed to keep millions of people that are now dying alive. That's giving them pills for malaria. That's giving them the pills, the antiretrovirals for AIDS. That's giving them the therapy for tuberculosis, what's called DOTS. Some of you may have heard, directly observed therapy, short course. It's making sure that there's the so-called oral rehydration therapy when children are dehydrated from diarrhea. It's giving antibiotics for respiratory infection. It's giving vaccines, about the lowest cost, most effective intervention for a lot of diseases. Do you know that there's still almost 1 million children every year dying of measles? Something unimaginable in the United States, where there are almost no children dying of measles anymore because of the measles vaccine. It's having a midwife at childbirth so that 500,000 women in poor countries don't have to die at childbirth. So we asked, how much would it cost? We made a list of 41 specific interventions, got the best evidence from around the world. They did a great job, I can say. I wasn't the author of that, so I can pat them on the back, even though they were part of this project that I was chairing. They did a fantastic job. And they found out that if the poor countries really stretch, there's a gap. The poor countries are too poor, as Ellen explained, to be able to meet their own needs. Because when you're living at less than $1 a day, you can't afford this, much less necessarily even being able to get the basic nutrition and clothing and shelter. So there was a gap. And the gap turned out to be $25 billion a year from the rich world. Now that sounds like a daunting sum, perhaps, $25 billion. Here's the thought experiment. Suppose out of every $10 you have, you're asked to put something aside. It could be pennies, dimes, quarters. Out of every $10, you're asked to put something aside. And you're told that if everybody puts that amount aside, 8 million lives could be saved a year by funding this kind of intervention. The vaccines and the safe childbirth and the AIDS and the malaria treatment and so forth. So out of every $10 you make, you're asked to not tithe. That would be perhaps putting $1 aside. Well, some people do that. But what would you be willing to put aside for that? Would you put a nickel aside? Would you put a dime aside? Yeah, I think almost all of us would.
would you believe that all it requires for that $25 billion is to put 1 penny aside for every $10 that we earn? That's all that's required. Because the rich world now produces every year $25 trillion. So putting 1 penny out of every dollar aside, that's 1%. That would be $250 billion. We don't need $250 billion to save these millions of people. We just need 1/10 of that. That's 1 penny for every $10. So I've asked myself the question, I've asked my neighbors the question, and I ask you the question. Would you personally, and do you think your fellow Americans would put 1 penny aside for every $10 if that's what it would take to save 8 million people every year? I do.
I do too,
I think
Jeff.
it would be slam dunk. Now, let me turn to what you saw in Senegal. I don't have the number in my head exactly what Senegal spends each year, but I'll make a guess that probably Senegal's health budget is on the order of perhaps $7 or $8 per person per year. You said they're on government salary. That's a telltale sign in a country at $300 per year, that what they're on is something that doesn't begin to actually bring forward the supply of doctors who can be working across town in the private sector or can be working in our city hospitals, because we attract thousands of doctors from Africa. And the Canadians go in and they recruit the doctors from Africa. Now, what a typical salary in Africa would be is that on the basis of that $7 or $8 per person per year for health, as compared, by the way, with what we spend for health, about $4,500 per person per year, just to keep the rough balance. For that $7 or $8, you may be able to pay a doctor $200 or $300 in some places per year, maybe in some places $75 to $100 a month when they're very well paid. Well, you know what? You can't get doctors in the world for $500 a year or $700 a year. Doctors, with their training and their marketing and their ability to operate in a global market, don't work for $75 a month. Neither do we. And we have to understand that the counterpart of that reality, that's not greed, that's normal. I worked with a doctor on this project who could not put food on her table for her children, not for herself. A doctor, by the way, an MD, PhD in economics from Ghana, who was my assistant on this health project. She, on her Ghanaian salary, would skip meals so she'd have enough money to feed her children. A doctor with a PhD in economics. And don't say the PhD took down the salary. So what I learned is that we can't pretend that poor countries can run their health systems at $7 per person per year or $8 per person per year. And we can't be shocked, because I've seen it too, when you go to a clinic and the doctor's not there, because they're not paying the doctors what it takes to get a doctor. And when the doctors are there, there's no telephone inside for sure. There's no drugs. There's probably not even a microscope. And there's probably not even electricity to keep vials of medicine refrigerated. This is not possible to operate public posts like this. And in our commission, incidentally, we had big fights. You know, there were people that said, oh, so much corruption, let them pay for it. But we actually looked at the numbers and asked, what can an impoverished country like Senegal really pay for out of its own income? The answer is not very much. Because when you're at $300 per capita, maybe you can stretch and spend 4% of your GNP for health, That gives you $12 per person per year. Maybe by some miracle you could spend 5% of your GNP, although almost no poor country in the world manages that. That would give you $15 per person per year. But what do you need? You need at least $35 to $40 for the barest essentials. The barest essentials. So I am not surprised, because I've seen it 100 times now, the empty health post. The doctor's not there, the drug's not there. But I don't call that corruption. I call that trying to run a health system for free. And it doesn't work. And we need to understand that money matters in this world. And when the poorest of the poor don't have it, that's where we come in with that 1 penny out of every $10.
Okay. I still don't think you've answered my question.
I'm trying.
I'm not sure you are. My question is, let me give you another anecdote, because they seem to work effectively. Leaving the car in a car with one of these magical physicians who seemed to be willing to work for nothing, I drove 3 hours into a village, and on the way, I saw an entourage. And in the entourage, there were about 14 Mercedes, the first 2 being limos. And the doctor sitting next to me said, "Oh, that is the president and his entourage going to his dasha. Now that the malaria meeting is over, he will go." Okay. His feeling was that there was misappropriation of funds in his own country. This is a physician working in Senegal. He did not feel that the country was appropriating funds in a way that would make it possible for him to feed his family as well as treat malaria, which he was doing pretty much pro bono in that country. But he felt that there was money to be had. Now, this could have been a myth, but I think many Americans feel that way. So I'm asking you once again, if we donate the 1 penny out of every $10 we have, what assurances do we have that this money, and how do you propose to make those and help us gain those assurances, this money will be applied effectively?
Well, for the second time in a couple of weeks, I'm going to follow Bono, who said the line vis-a-vis George Bush, and I'm going to say it vis-a-vis you. It's Ronald Reagan's line, of course: trust but verify. You don't just give out money, ever, especially not such large sums. Public health itself operates in a system, and money needs to operate in a systematic way as well. The beauty of this new global fund to fight AIDS, tuberculosis, and malaria, which is a fund which Kofi Annan pioneered and launched last year, and which has just started operation after Secretary General's inspiration and some money coming in from the rich country governments to start the fund, works on the following principles, which I think are important. First, the countries themselves have to design a strategy to get the money. No one's going to fly helicopters across and drop money out of the windows. There needs to be a strategy. Second, the strategy can't just be designed by the government. It has to include what we call civil society. And that means outside groups, non-governmental organizations, perhaps the church mission hospitals, perhaps Save the Children or Oxfam or Doctors Without Borders, perhaps the medical school of the country, and so forth. And the countries actually have to come up with a specific mechanism for bringing government and civil society together in writing the plan. Then the plan goes to the fund, and an independent expert group reviews it. Does this make sense? Is there plausibility in this? Is this the way that best practice suggests? Can we give some advice, or should we send this back and say this really doesn't make sense or we don't believe it? Then, when the funding starts, you have to have independent monitoring and auditing, as you naturally would with any such program. And that's also quite feasible, especially because you've gotten civil society involved to watch the government, so that if the doctors or others say, this isn't getting where it's supposed to be getting, then you hear quite early on. So this is just one illustration of how you can actually make things work. Yes, it's trust, but it's with strong verification by the scientists, by the auditors, by the finance monitors, and so forth. And if you think it's pie in the sky, a pretty good businessman started this model a couple of years ago for immunizations, not for AIDS, TB, and malaria, but for immunizations. That businessman is Bill Gates. Bill and Melinda, of course, have donated a pretty nice sum, even more than a penny out of every 10 of their dollars. They gave $24 billion to start the Bill and Melinda Gates Foundation. And from that foundation, they gave a gift of $750 million to create a vaccine fund. And that vaccine fund funds a process called the Gavi, which is the Global Alliance for Vaccines and Immunization. And it operates exactly on those principles that I just said. The countries have to make the plans. They get submitted to an expert board. Then there's monitoring. Actually, Bill insisted, we're not going to give the full payment until we verify that the immunizations were actually given. So only part of the money goes at the beginning, and the other part goes after confirming the delivery of the services. Now, I just saw today the most recent newsletter from that fund. They are achieving spectacular success of increasing the coverage rates of vaccines. And they found dozens and dozens of countries that have gotten organized to respond because people are desperate to stay alive, because communities and NGOs and well-directed governments are around. I don't think Mr. Mugabe applied to that fund, Mr. Mugabe of Zimbabwe. I don't think he'd get funding. I wouldn't recommend it for a moment right now, not through him. That's a tragedy for the people, but there's no doubt you couldn't trust his government with this money. But there are so many good governments around that somehow get tarred by association, whether it's the Tanzanian government or the Malawi government or the government of Botswana or the government of Ghana, which are just desperate for some real help right now. So I think your points are well taken, and I think they're right. And I don't think every government is pure and noble, including some of our own. So you have to watch and you have to verify. And you have to make sure that there's an independent view of all of this. And you certainly don't just transfer money on a whim. That is not what I'm talking about, because this is big time and real, and the stakes are too high to mess it up.
Can I get on to the next question?
Absolutely.
You mentioned vaccines. We do not have an AIDS vaccine. It would be wonderful if we did. I think there is a test going on, or will be soon in Botswana. We are very hopeful. But we don't have one, and the alternative, as you've mentioned before, is antiviral medication. Many experts on the ground in the developing world do not think it's practical to provide antiviral medication to people in the developing world for all the reasons you mentioned. Lack of infrastructure, medical support. In addition, they're concerned about people developing immunity to these drugs, especially if they're not taken prophylactically. I do share that concern, and I wonder how you would respond in terms of balancing prevention efforts, which are also difficult with drug efforts. Even in India, a country with only 4 million cases at the moment, a vanishingly small amount compared to Africa, they're having great difficulty controlling it with drug treatment, even though the drugs have been made available, at least supposedly made available. Okay, that's just propaganda. We're told that they are, by the drug industry at cost. If 4 million cases of AIDS cannot be contained in India with drug therapy, how can we possibly do it in Africa, even under the best circumstances, even with excellent governance, even with no corruption?
Let me just clarify a couple of things. India has some manufacturers of these drugs, but the Indian people, just like the people in Malawi, can't afford them. So these companies are exporting them or supplying them for the few that can afford it. But the Indian government, to my regret, has not made it a policy to support the actual provision of these drugs. And they face the same kind of financial stress that the other countries we're talking about face, so that they need some help to do it anyway. So it's not true that there are 4 million people despite drug therapy. There isn't the drug therapy in India, even though there are some producers of the drugs. The people that are sick and dying can't afford the drugs, and so far there's been no system to make them available.
Let me modify that just a little bit, because even in areas where the drugs are available for free, the complaints have been that people have not accessed the drugs.
Well, I don't know. Actually, that's the first I've ever heard that.
Well,
I don't know of places where these drugs are available for free. What I do know is that when I stood at that corridor in St. Elizabeth Hospital, which I mentioned to you, it wasn't a problem of infrastructure. It wasn't a problem of doctors not being there. It wasn't a problem of patients not wanting to live. It was one side of the hall you lived, and in the other side of the hall you died. And you were on one side or the other depending on whether you could afford $1 a day. So that's a different matter. And that, to me, is actually the lie to this general proposition that there's nothing that can be done. It's at least it can be done in that ward, that's for sure.
But Jeff,
because the doctors are there, and across the hall they're treating them.
Yes, but Jeff, you're talking about a have-not situation in which, presumably, since the people could afford $1 a day for the drugs out of their own pockets, they were a wealthier cohort of people than the people across the hall who were devastatingly poor. So let us say that we provide the people across the hall with the medication, and yet their nutrition is equally bad. They're still anemic, they're still vitamin depleted, they still have upper respiratory infections, they are getting treated for AIDS, okay? The likelihood is that the outcomes on those patients on that side of the hall would not be as good as the outcomes for the patients who are paying their own way.
Well, I have some doubts about that, since I've seen also with my own eyes the success of treatment in the very poorest settings in the world, where a charity or an NGO has tried to do this. I would tell you we have a veritable saint in our midst in the Boston area, Dr. Paul Farmer of the Harvard Medical School. Many of you have probably heard about the miracles that he does in Haiti, where he, for the last 18 years, has run a program in the central plateau of that country, where I can tell you it's as poor as any place in Africa that I've been. It's shockingly poor, especially given that it's an hour-and-a-half flight from Miami to Haiti. So it's almost mind-boggling how one could have that kind of poverty in our midst. But Dr. Farmer works there. He's run a tuberculosis clinic for 18 years with a tremendous success rate, which has become legendary because his patients want to stay alive, and he's figured out some good tricks to help them stay alive, including training often illiterate members of the community to be real community health workers who can help people with their pills, help to make sure that they have what's called high adherence to their prescriptions and so forth. Well, a few years ago, Dr. Farmer found that lots of patients with AIDS were showing up in Haiti because Haiti has the highest prevalence rate in the Americas, probably about 4% of the adult population right now. It's quite a staggering pandemic. And being the kind of person he is, he says just because you're poor doesn't mean you have to die. He started finding every means he could to get antiretrovirals, and he made a system for patients in Boston that were changing their drug regimens to donate the excess drugs. He went to various charities. He went and begged from pharmaceutical companies, and he was able to get a supply for his clinic. It treats probably 50 to 60 HIV-infected people. Now, when you see these people and their will to live, and I went and saw these people out on their farm plots, I tell you, it was there are no roads, there are almost no paths. This is the most impoverished place in our hemisphere. It's shocking. But these patients have responded brilliantly to the drugs. They are highly adherent. The system which he devised for TB is now working for the AIDS patients. People that were on their deathbed by the time that they landed in his clinic are up, around, and greeting us in the villages with their children around and their families intact. And this is the kind of thing that can be done when there's the will to do it. Again, not everyone is going to be saved. It's true. But Dr. Farmer found that his poor patients are even more adherent than his patients in Boston. In Boston, he's dealing sometimes with intravenous drug users or others that are more marginalized in their own populations than his patients. His patients are poor, but they're not marginalized. They're poor members of their communities with the same will to live and the same ability to take the pills in the morning and in the evening and to stay alive and get good results. He's got a terribly nasty slide, by the way, of me standing next to one of his patients. And she's a big woman who, when she arrived at his clinic, was weighing probably 80 or 90 pounds. And she was near death, and he has restored her to full size, and it's full size. And he's got a picture of me standing next to her, and when he gives grand rounds, his caption is, "Who weighs more, the patient or the economist?" The point is that he's gotten good response, and it's marvelous to see. I saw this woman actually at her place, as modest as you can imagine. It had a corrugated roof, of course, no floor, no dirt floor, and no electricity, no anything, children without shoes. But she greeted us on a little wooden table. She came in from the fields where she was working that day. Her children were around, and we sat and had a juice drink and had bananas and saw a woman that was staying alive, and it was a wonderful, wonderful thing to see.
Well, before I ask the audience for a question, I just have to bring this up because my friends at the School of Public Health would think me remiss if I didn't. Paul Farmer is a charismatic and, as you said, a saintly guy who's been immortalized in the New Yorker, and I think will soon be immortalized in a book by Tracy Kidder. He's a wonderful man. He's doing wonderful work. He's doing this work with the help of many of his medical students from Harvard. He works with a relatively small cadre of clients and patients in Haiti. And I'm wondering, can you give me one example, or more than one example, of where this kind of program has been increased in scope and does not involve a charismatic, personality-driven program with a man from an appointment at Harvard University who avowedly steals and proudly steals supplies from Harvard every time he comes up. More power to him to bring back with him. In other words, Paul Farmer is the poster child for this kind of thing, and we're very happy about what he's done. I'm wondering, can we extrapolate it to a larger country, to a bigger problem? It's a microcosmic example.
Yeah, as I've already said, when we put our mind to it, we got the immunization rates for the basic vaccines up to 80% in the poor countries until the donor funding lapsed and it went back down again. We've gotten African river blindness under control through large parts of Africa. We eliminated smallpox. We're in the process of eliminating polio, an even trickier disease to control. We've made huge progress in recent years on leprosy, on African guinea worm, on trachoma. It's a matter of the will and the resources.
Okay, let me open it up to questions now, if you don't mind. Please go to the mic. Sorry, I was told to do that.
Professor Sachs, thank you for a terrific eye-opening forum.
Thank you.
Two questions about the AIDS crisis in Africa. One, are there any countries doing, in your view, at least in relative terms, a decent job in their attacking the problem of treating AIDS? And secondly, in Africa, or in general, can you talk about prevention versus treatment, the emphasis of each?
Thank you very much. You need a comprehensive approach. Treatment without prevention won't work because the disease will continue to spread and one will never get it under control. Prevention without treatment is very naive. It's just impossible. One can, in some cases when you're at the very start of the epidemic, maybe it's possible to do things. But once you have lots of infected people, if you're not doing treatment alongside the prevention, you start to face terrible problems. First of all, people won't come in for testing. Because why get tested if all a positive test does is give you a death sentence? Stigmatization, exclusion from the community, but no hope for treatment. So you'll be amazed, I was absolutely amazed to learn that probably 95% of Africans don't know that, of those that are infected, don't know they're infected. Well, how are you going to control the pandemic when you don't have even the people infected knowing it? How can that be, by the way? It's because it takes many years of a latent period before the disease shows, and during that time the virus is being spread. So in the United States, the Centers for Disease Control calls treatment a secondary line of prevention because they regard the model of counseling and testing as a major channel to get a pandemic under control. It brings people into the testing center, and then when they test positive, they're put on treatment and they're counseled about the further spread of the disease. So you've got to do both without question. Some countries have done relatively well at prevention. I think what's usually said, and it's probably true, that Uganda and Senegal have made progress through prevention efforts. But even there, it is, there's some dispute about how far they can go with that alone. No country in sub-Saharan Africa has made a major advance on treatment because none can afford it. Botswana is starting to scale up on the basis of a Gates and Merck Foundation, Merck Company and Gates Foundation, a grant of $100 million to scale up, but that's just starting this year.
Yeah, I was just wondering, you're talking about obstacles to the will to give, basically on the part of rich nations, and I'm wondering, maybe this is too simple an explanation, but if you could speak about racism and the role that racism plays in our decisions about foreign policy, and maybe not even racism, but a certain view of Africa that we have, what the economists called so nicely the hopeless continent.
Right. Well, thanks for asking. You know, people think of Africa as just one huge, uncontrolled mess, and they don't make the distinctions. There are places that are in conflict right now. There are places so badly governed I wouldn't know where to begin. But there are also places of great hope and great promise if they can get some help. And I like to remind people Africa has 49 countries in the sub-Saharan region. And there's a lot of variation in those countries. Some are in war, and if you don't stop the war, you're not going to really get the medicines working. Some are so terribly governed, like Zimbabwe, that a real thuggish regime can bring the whole country down, and that's what Mugabe is doing right now. But some are governed by democracies that are simply overwhelmed by poverty and by disease, and they're the ones that need our help. And they're the ones that are able to put together proposals They're the ones that are able to deal with civil society. They're the ones that are able to get down into the communities. And so we have to differentiate. And I strongly believe if we help those that want to help themselves, we're also going to be sending a very powerful political message to the thugocracies, the places ruled by the thugs, because their people will see that there's real hope if they can get past those disasters. So we'll put pressure on the bad governments much more by helping the good ones. Right now, we don't, we just don't make these fine comparisons because, frankly, most people, and I'm speaking of our politicians often, don't make the distinctions at all.
Dr. Sachs, I want to verify very strongly what you are saying. I have worked for over 40 years in mother and child health programs in Africa, and about 15 years I was an independent evaluator of USAID-funded health projects in rural areas. And again, I found that the locally managed, low-cost, community-based health programs focused mainly on mothers and children with community health workers, as you were describing them, were very cost-effective and very efficient and saved many lives. And I worked in the St. Elizabeth's in Blantyre, for example. There's no question that we should be channeling more funds through those kinds of outlets, and the U.S. government, your tax money is going to those groups, such as Save the Children, Salvation Army, World Vision. They really work. And I am an independent, and I'm not paid by them. I've never met Dr. Sachs. I promise you that's verifiable, and if anyone wants good data, I've got it. I do have, however, one criticism, Dr. Sachs.
Yes.
You have to take the bitter with the sweet. I think it's extremely tragic that you have not mentioned, either of you, when we have to talk about prevention, we have to talk about condoms. And you didn't mention the C word, and I hate to say it in the Kennedy Library, but the fact is that the only way we're going to prevent the problem from getting much worse, far beyond the 40 million, is condom promotion. And unfortunately, the Catholic Church is a major obstacle to this. And I would like you to comment and suggest specific ways that we, as a nation, as a caring community, can do something about this problem, because I think it's an enormous problem.
I think you make a fantastic point. I think you make a wonderful point. And I was a couple of weeks ago in Abuja, Nigeria, at a meeting that President Obasanjo called, and it was a wonderful day. President Jimmy Carter was there, and he has helped to lead in public health when nobody was talking about this, and he's just shown the kind of energy and dedication that is unparalleled. And there was President Carter standing up and basically giving a speech about condoms and saying, this is what we need to talk about because this is what's going to save lives. And what's interesting is that he went with the health minister of Nigeria on the one site visit they took that morning was to the red light district to meet with the commercial sex workers, because the first rule of this kind of epidemic, a sexually transmitted epidemic, is that so much of the transmission is taking place through the commercial sex. And you find in typical surveys, the medical surveys, the epidemiological surveys, that maybe 80 or 90% of the prostitutes in formal commercial sex are infected. And if they don't use condoms, that's where, or their clients are using condoms, that's where the transmission is so intense. What Thailand did to break the epidemic, it was still at a very low level, but they really caught it at the beginning. At the very beginning, was by promoting the use of condoms with the commercial sex workers, and it was a very, very powerful and key intervention. So you're exactly right.
Can I ask you a question, sir? When you were on the ground in Africa, did you observe much of the use of a female condom?
No, it's really expensive. I mean, there are a lot of technical problems. It's noisy and sticky and problems, personal problems people have with it. But it's $2 or $3 as opposed to 5 or 10 cents. But I want to add another dimension to this. The reason we're very uncomfortable about male condoms is that traditionally we have focused on women. Maternal and child health and family planning is almost entirely focused on women. And so to start getting men into the picture and to start talking about sex, which you have to do when you're talking about condoms, that's what makes us very reluctant, all of us, to get into this issue, and I think that's why it wasn't mentioned tonight.
Thank you. I'll call the next person.
Yeah.
Another thing to transform, right? Another issue to deal with. One of the things I'm hearing is the idea that, like resignation. I'm a therapist and I'm an activist with kids, and and like resignation. What's going on in Africa, how people really are, what we can and cannot do. Resignation is a tender trap. And it seems to me, as I'm listening over here, half the battle is changing my own mind. And really, it's constant. I mean, every moment you speak, I have to constantly reshift my thinking and open up my mind to that this is possible. Like Bucky Fuller said, there's nothing more powerful than an idea whose time has come. And I'll just say what comes to my mind and then I'll shut up. Like Kennedy, when he said, we can go to the moon. Well, there was no evidence at that time that we could. There wasn't even a department created. And he said by the end of the decade, we will be on the moon. So it just seems like this is the work for visionaries and daydreamers, and also people who are educated and not educated who want to do the hard work and put it all together.
I thank you for...
And one last thing, how can I get information out? Like in the back of a resource I'm putting together. It's called, it doesn't matter, it's not published, but, for a passionate cause, as an example, to give to people. How can I get information about this cause to put in my book?
Yeah. I think we all always have shivers down our spine when we're reminded or see the clip of John Kennedy saying in 1961 that by the end of this decade we're going to put a man on the moon and bring him back safely to Earth. And of course he knew his scientists and engineers were telling him it was feasible, but they didn't quite know how they were going to do it, did they? They just knew it was something that we could do. And here is the same thing. We don't know exactly how we're going to do it, but we've gotten so rich and our technologies are so good and we have such means that we can accomplish wonderful, wonderful things when we put our mind to it.
Excuse me.
I wish I were as hopeful as you all were concerning the interest of the American people. I'm disappointed that much fewer people are here tonight for this particular forum on ending global poverty than were here when the celebrities were here, basically, like Christiane Amanpour and George Mitchell and Harry Belafonte. So, I still think that the word needs to get out to the American people that a lot needs to be done and can be done. And, when you, Michelle, say that, it's you make it sound as if it's futile, basically. But we've been putting most of our foreign aid budget into Israel for 50 years. And what's happened there? They're still killing each other every day. And you asked Dr. Sachs, or you seem to be saying nothing can be done, but you don't give another solution. What do you think should be done? We can't just let people die. I know you said you were acting as devil's advocate,
Right,
but
right.
we can't just let people die. And just one other thing that I heard that more money is being spent on research for treatment and medicines than there's being spent for vaccines or a cure. I mean, 8 times as much money is being spent by the drug companies for treatment, right, which benefits mostly people in the Western world and people in America than they're spending for vaccines. So I just throw all that in.
Let me take up a little bit of it. Just a point about our foreign aid, first of all. We are, I believe, generous people in this country. And every survey says that American people consider themselves generous and want to be generous. And I think many people believe we have been generous, but what people don't really know is that over the past 40 years, our foreign aid has shrunk so much compared to our economy that we actually have the smallest share of our income going to development of any donor country in the entire world right now. If you can believe it, we're 22nd out of the 22 donors in the world. So people are surprised when they hear that. I do think the word is starting to get out. I do think people are thinking about it. We heard President Bush turn the corner, I think, last week when he said we have to do more. And when they start looking at the numbers, they're really going to have to do more, because to do this seriously is going to require a serious kind of commitment. I believe it's going to come. I also know that Bono has done amazing things to help spread the word about this, but many other leaders in public life, big personalities, people in the entertainment world, athletes, are clamoring right now to get involved. And so I think we're going to start seeing, I'm just guessing, but it's an educated guess, I think we're going to start seeing a lot more public knowledge, awareness, and activism in the coming months on that. And that's going to be very heartening, and I think it's going to do a lot of good for this country.
I am very grateful that you had mentioned Dr. Farmer. He's very much liked in Haiti. We do appreciate the work that he's doing. Ellen also was asking if there is another place where, or if there is another example where things of that sort had worked. I must say that the Albert Schweitzer Hospital has gotten really very good results as well, and this is why we very much miss the Mellons. They both passed away, but they were very much loved in Haiti. But it turns out that in Haiti we do have that kind of luck to encounter people like the Mellons and also Dr. Farmer. Since we're talking about Haiti, I must say the situation is very desperate as it is right now in Haiti, and unfortunately the Bush administration, had frozen all the funds available for Haiti, money from the World Bank as well as money from the international monetary funds. The situation is very desperate. There is a potential this country could become really like an Afghanistan. I'm asking you if you have any solution. I mean, as Bill Clinton really said, that we could not allow people like Bin Laden to present themselves as really the defenders of the poor. That we should not really allow that. But yet again, as John F. Kennedy has said, and also Franklin Delano Roosevelt has said the same, a nation that cannot feed its poor can neither guarantee the security of its richer people. So I think there is really that kind of potential in Haiti. What do you suggest at this point?
There are certain places in the world where American foreign policy is so bizarre, so hard to understand, that
I find myself perplexed and dismayed, and Haiti is one of them. Nigeria, by the way, is another. Haiti has its first, perhaps the only, popularly elected president in its history of great popularity, Jean-Bertrand Aristide. He is, without doubt, revered throughout the countryside. I spent days walking in the countryside in Haiti and hearing the reverence for this man. Now, our foreign policy is tantamount to toppling him, actually. I don't know whether that's the direct intent or whether it's just the inadvertent, profound error. But we have put such a squeeze on that country right now that it will explode, just like you said. We have frozen, since the day he came into office, we have frozen all assistance to the country in the midst of a terrible humanitarian crisis. So I understand why people think he's a dangerous, I mean, some right-wingers think he's a dangerous left-winger, and all sorts of, to my mind, very misguided ideas. But the practical point is we're squeezing that place till it explodes, and whether we want boat people drowning on their way to a desperate escape to the United States, or massive violence inside, or to bring down a democratically elected government, I can't figure it out, but we're on a course that's very dangerous with our foreign policy right now. I want to say a word about Nigeria also. That's a country of 120 million people, which after one of the most ruthless and corrupt regimes anywhere in the world, had the tremendous fortune, and for the world, the tremendous good luck of having a wonderful Democrat elected as president, President Obasanjo, who was in jail for his democratic views, who in exile was chairman of Transparency International. This is a man of absolutely wonderful, wonderful leadership qualities and deep moral sentiment. What are we doing in the United States to help him? Almost nothing. When September 11 came, I'm going to just, it's just, I think, important to, to carry on for one more moment on this. When September 11 came, there was President Obasanjo with the divided country between Muslim and Christian populations and all the instability that entails. There he was right next to President Bush saying, "We stand by you. Come what may, we're with you." But where are we next to him when he needs the help which he's desperately asking for?
Americans are a generous and compassionate people, but moreover, we respond well when our self-interests are threatened. Certainly, when you think about infectious diseases, now, we don't have too much to worry about for malaria because we don't have the pool of the parasite and the insects to spread it. We don't have to really worry about HIV because we've got condoms here and we've got drugs and we know how to prevent transmission. Tuberculosis may be something different, particularly if you look at the multi-drug resistant TB in the Ukraine, that may well threaten us directly. When I heard you speak about this 2 years ago in Durban, you talked a bit about the ramifications of the orphan children and what they might be like as they grew. You certainly spoke very eloquently about the loss of the infrastructure, the teachers, the farmers, the doctors, the nurses, the lawyers, the government workers, the machinery that helps a country run. In thinking about that, do you see any places in Africa where that loss of infrastructure is threatening our well-being as Americans, and could that then be used as a persuader for our generosity?
Well, thanks for asking. You know, now we can just look at the speech that President Bush gave last week, where he made this point, and I think he made it very, very, very accurately. He said poverty does not make murderers of poor people, but he said that poverty creates a breeding ground where the parasites of violence, of criminality, can take hold. And so I think he nailed this debate we've been having in this country since September 11 very well. Said development is in our security interest. not because poor people are going to kill us, but because their societies are so unstable. And he may as well have been citing a CIA task force that's been operating for the last few years called the CIA Task Force on State Failure, which is looking for the reasons why there's collapse of societies. And that collapse seems to pull us in, whether it's Somalia or Afghanistan, of course, or so many other places, pull us into military involvement, very expensive, risky, involving loss of life and huge expenses for the country. You know what they found as the three biggest predictors of state failure in the future? They found first, maybe not surprisingly, that autocratic regimes, non-democratic regimes, are unstable. Second, they found that closed societies, those that aren't engaged in international commerce, are more unstable, more likely to fail. But the third indicator they found that was the most significant, that was of the three were the most significant of hundreds, was the infant mortality rate. They found in high diseased environments where there's tremendous disease burden, lots of death, there is lots of instability. And of course, it's not just the infant mortality, it's the sign of public health in disarray, whether it's AIDS or malaria or TB or all of the other killer diseases that we've mentioned tonight. I think there's no doubt that this poses profound chances of destabilization. When people are sick, when they're hungry, when they're dying, the risks multiply tremendously. And of course, I would say also, though, that the spread of the pathogens themselves, of the diseases, can come and get us. You say we don't have to worry about AIDS, but of course we have nearly 1 million people HIV infected in the United States, and that's a disease that did spread from Africa and wasn't really recognized until it had already taken hold as a pandemic disease. I think your point's very right, very well taken, and I'm glad that the President is now on the case as well.
I think we have time for one more.
Thank you. I'd like to first make a little broadening statement about Paul Farmer. You've asked if we could extrapolate what he does. It's a just narrow no. He works very closely, in fact, is almost not the titular head, but the emotional center of a group called the Lambie Fund, which is a development, sustainable development of small indigenous projects in local communities all throughout Haiti. It's one of the best development projects that you can find. I work with a church-related development fund here in Boston, and we selected him right away as a partner to get development aid into the rural areas of Haiti, and this is really pro bono on his work as a doctor. Other people, indigenous people, actually carry that out. A question, I've got many, but one, would you take us back and make a connection to the debt crisis that we all focused on in the op-ed pages a year and a half ago, and where we are now, that we went through the Congress, all the money was given to the IMF and the World Bank. You've been back in Africa. Has it made a difference? You've also, as economists, have watched what the World Bank did with the money, what the IMF did in reevaluating the gold. Did that work? Or are they squirreling that away into some other sort of Enron-type accounting? I mean, I'm very dubious about those two institutions after a year of jubilee. So give us some connection on that, please.
Thanks a lot. One of the reasons that Bono and I went to Africa in January was not only to see the state of the AIDS epidemic and what can be done, but also to look at what had happened with the debt. So we spent a lot of time on that issue in the three countries I mentioned, in Malawi, Uganda, and in Ghana. And the news was very good, actually. The news was very good. In all three countries, groups had formed to work with the government to actually use the savings from not paying the debt to channel them back into social programs. In Uganda, it's clear that on the basis of what's saved, they're getting the kids in school now. This was a tremendous breakthrough. We visited a little water project that was clean water for the villages that was funded out of these social savings. In Malawi, they've gone through a detailed process of rebudgeting the money. It actually hasn't started arriving yet because they've been so careful and gotten public approval, parliamentary approval, civil society approval, that they've gotten a very nice plan to scale up health and education on the basis of this, and it's about to get going. So my sense was this basic idea of get the communities involved. Don't just rely on the institutions and government, but get the communities involved to really check on what's happening is actually working in a leading front in that case.
If I may, let me bring Mr. Sachs to the answer to our problem. And that is,
I'm really sorry,
Oops.
but you know, we can talk later. But I'm sorry, these forums do end on time at 7 o'clock. In closing, I want to return to the family of man speech of President Kennedy that I quoted at the beginning. Because when President Kennedy concluded that speech, he said, "It is essential that word go forth from the United States to all who are concerned about the future of man, that we are not weary in well-doing, and we shall, if we maintain the pace, in due season reap the kind of world we deserve, and deserve the kind of world we will have." Professor Sachs, I thank you for helping to build that world. Ellen Schell, Professor Schell, I thank you for helping bring out the information about it, and I really am very grateful to you both for an extraordinary forum. Thank you. Thank you.